Hello, and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar series for December 15th, 2021. Thank you for joining us this month. Our presenter today is Jason Franz. Dr. Franz received both his Bachelor of Science and his Master of Science degrees in Engineering Mechanics from Virginia Tech. And after serving as a staff scientist in physical medicine and rehabilitation at the University of Virginia, received his PhD in 2012 in integrative physiology from the University of Colorado Boulder. He then completed an NIH postdoctoral fellowship in the Department of Mechanical Engineering at the University of Wisconsin-Madison. In 2015, Dr. Franz joined the Joint Department of Biomedical Engineering at the University of North Carolina at Chapel Hill and North Carolina State University, and is now an associate professor and director of the UNC Applied Biomechanics Laboratory. He currently serves as principal investigator or co-investigator on multiple NIH-funded research projects, all predominantly focused on rehabilitation engineering strategies to mitigate age and disease-related mobility impairment and falls risk. Dr. Franz's talk today is titled In Vivo Imaging, Muscle Neuromechanics and Rehabilitation for OA Prevention. Welcome, Dr. Franz.
Thank you for the invitation and the introduction. Can you hear me okay?
Yes.
Good. Does everyone have their lunch ready? Answer. I've spent the last 15 minutes scarfing mine down, but I welcome you. You can totally eat while I talk. I won't be interrupted, I promise. I also noted some familiar faces in the participant list, so it's nice to see some friends here. And some of the content, if not, much of the content here might be stuff you've seen before, but the more perhaps we think about these ideas, there might be new opportunities for collaboration. But as you heard in that introduction, I direct the Applied Biomechanics Lab, which is in our Joint Department of Biomedical Engineering, UNC and NC State, fully joint, both at the undergraduate and graduate levels, as well as our faculty. And the goal of my lab is twofold. One, I want to collaborate with our students and our faculty collaborators to understand the mechanisms involved in losing one's independence in our community as we get older. And I'm going to leverage that newfound understanding to engineer new strategies, devices, and approaches to mitigate that loss of independent mobility, to mitigate the risk of falls. And this mission is very familiar to many of us because, many of us have had or are currently having older relatives, older neighbors that we've watched suffer from declines in physical function and mobility and an increased prevalence of falls. This one here happens to be my grandfather. And like many of your older relatives or neighbors, I watched him go from just being the strongest, most physically fit and capable person I knew to becoming physically weaker, to becoming frail, to falling more often, certainly suffering from the degenerative impact of osteoarthritis. And so that's the motivation for all of the work that we do. And with our short time together today, I'd like to follow a pathway that we think is taking place on a step-to-step basis that we think ultimately contributes to the onset and development of osteoarthritis. This is a relatively new area of research in our lab over the last couple years. And what I hope to do is to introduce some new things here about the role of muscle itself in this pathway. Some of this might be biomechanical, some of this might be inflammatory, but ultimately we propose that those two things are actually highly interconnected. We also think that some of this pathway might be common to both post-traumatic osteoarthritis following knee joint injury earlier in life and idiopathic osteoarthritis later in life. And I'd like to sort of characterize our work in both of those areas. Now, much of our work here at UNC is performed in collaboration with folks at the UNC Motion Science Institute. Some of those have actually performed or come and given this particular talk, this Lunch and Learn. And they, for years, have studied ACL injury and reconstruction as a model for the development of osteoarthritis, specifically post-traumatic OA. And there's well-documented strength and activation, muscle activation deficits in the quadricep muscles following ACL reconstruction. And those are at least accompanied by altered knee joint biomechanics during walking considered relevant to osteoarthritis. But because the quadriceps muscles themselves are by far the largest contributor to joint contact forces during walking, those changes are thought to alter cartilage loading patterns to magnitudes and with locations that aren't protected by prior loading experience. And there's a lot about this. We're calling it a neuromechanical cascade that we simply don't understand. But allow me, as you eat your lunch, to focus on what I think are two major opportunities or gaps in our understanding here. The first is that deficits in quadriceps force generation and subsequent changes in gait biomechanics, they're not simply governed by weakness and neural changes, inhibition. The actual mechanics of the muscles involved here really aren't well understood, even in healthy and uninjured adults. And the second is that most studies trying to associate altered gait biomechanics with altered cartilage loading, they're purely observational. It makes it nearly impossible to establish cause and effect relations between factors that may predispose to osteoarthritis. And so, if we can overcome those, even some of those challenges, we think we might be able to identify new and more effective translational opportunities for OA prevention. Now, there's three skills that our lab brings to this table to address these gaps with our collaborators. So the first, ultrasound imaging, looking under the hood at the muscles powering locomotion. Real-time gait biofeedback, super simple idea, providing you with information about what you're doing in the hopes to steer that in different directions. And then lastly, musculoskeletal modeling. When we physically can't measure the thing we're interested in, maybe we can use the computational power of models to do that. And our original work here set out to address two main questions. The first is, how does joint injury impact quad muscle mechanics underlying gait biomechanics relevant to OA? And the second is, can we actually manipulate joint loading and tissue biochemistry to optimize rehab and prevent osteoarthritis? Now, we know that quad dysfunction after ACL reconstruction is accompanied during walking by reduced peak knee extensor moment, which you can see here on your left here, and knee flexion excursion, which you can see on your right. Both of these changes are evidence of quadriceps avoidance during walking, but this is clearly an incomplete story because, conventional resistance training, it can restore muscle strength, but those interventions do little to actually mitigate these gait changes. And like I said, in vivo imaging provides a way to look under the hood, discover how these muscles are actually operating to produce the knee moments and emergent joint contact forces considered so relevant to OA. Specifically, we actually focus on the vastus lateralis, which is on the side of your quad, because due to its size, it's actually the biggest contributor to joint moments and contact forces at the knee. And so what you see here in this plot is length change of the entire muscle tendon unit. So this is from proximal to distal bony attachment. And we focus on the shaded region, the weight acceptance phase. And here the quad muscles are generating force to actively resist knee flexion and muscle tendon unit lengthening. However, if we image the muscle directly, we actually find something really surprising. And that is that as the knee is flexing and the entire muscle tendon unit is lengthening, the quad muscles themselves are actually receiving sufficient activation to shorten as the joint is being loaded. And what that implies is that tendon lengthening, not muscle lengthening, is more responsible than we've appreciated in governing the forces that are generated by the quadriceps during limb loading and walking, at least in uninjured controls. Which brings me here. So what happens following ACL injury and reconstruction? Well, let's retake those same measurements during walking in individuals 6 to 12 months after reconstructive surgery. And as a reminder, these individuals walk with big reductions in knee extensor moments generated by these muscles. The forces are lower. And here we see that quadricep muscle action in the uninjured group, the uninjured contralateral limb, is not really different, indistinguishable from uninjured controls. But we see fundamentally different behavior on the reconstructed limb. Only there do we actually see significant muscle lengthening during limb loading, something even more surprising, given that this limb is going through much less knee flexion than uninjured controls. So what does this mean? Well, we have two possible explanations, both of which we think are relevant to strategies that might optimize knee loading following joint injury and ACL reconstruction. The first is potentially because of insufficient muscle force, the muscles themselves may be either succumbing to the demands of walking or actually shifting to eccentric muscle action as a compensatory strategy. And then the second is that these individuals may operate their muscles in a way to avoid excessive tendon lengthening, something especially relevant in these subjects who all received patellar bone grafts. But what we're getting more and more excited about, interested in, is there might be significant inflammatory consequences associated with early signs of cartilage and bone degeneration. As a first takeaway of this talk, really, these data suggest that the quadricep muscles themselves may serve as a marker of recovery or a target for intervention to reduce the risk of post-traumatic OA in individuals following ACL reconstruction. And those inflammatory consequences there, that's all animal data showing that lengthening contractions might change the inflammatory state of the joint. All right, so our second key question to start with here, can we manipulate joint loading and tissue biochemistry to prevent OA? And again, here, we're trying to move beyond merely observing differences between groups. We know that people following ACL reconstruction walk in a way that we would suspect, based on this curve at least, to underload the articular cartilage compared to uninjured controls. And this idea of underloading has implications for cartilage tissue integrity. It was about 3 years ago, we showed that individuals with less limb loading, measured here by smaller peak vertical ground reaction forces on the y-axis, they actually exhibit larger changes in serum cartilage matrix protein, or COMP, on the x-axis after just 20 minutes of walking. What that means, it suggests more cartilage breakdown in individuals who exhibit less limb loading during walking. Now, as I mentioned earlier, we're really interested in biofeedback, both as an experimental tool and ultimately as a means to enhance or optimize rehab. And in the study here, we set out to determine if augmenting limb loading during early stance and walking using biofeedback could also augment that biochemical response relevant to cartilage tissue integrity. So here, on different days, separated by about a week, subjects are going to walk while watching a video screen showing their instantaneous peak vertical ground reaction force that we measure from a treadmill, a forced treadmill, on a step-by-step basis. And they're going to see a target line that's going to represent usual loading, lower than usual loading, and higher than usual loading. And we're going to measure the change in serum COMP following 20 minutes of walking with each of these biofeedback conditions. And the key outcome from this study is here. We found that prescribing higher than usual loading with biofeedback actually decreases the change in serum COMP, suggesting that we can augment joint loading and tissue biochemistry using biofeedback. The challenge here is that peak vertical ground reaction force is sort of a limb level indirect surrogate for knee joint loading. So we're interested in, can we more directly target the knee? Well, simultaneously in our lab, we've been performing more direct real-time estimates of peak knee extensor moments on a step-by-step basis using biofeedback and all of our fancy equipment in the lab. And those estimates agree pretty well with those you would get from inverse dynamics, how the laboratory typically goes about calculating these in a really time-intensive way. And here, what we're going to do is we're going to encourage we're going to use visual biofeedback to encourage subjects to walk with larger than normal peak knee extensor moments, are the dots shown in green, and to walk with smaller than normal peak knee extensor moments, which are the dots shown in blue. And in doing so, you can see here that we can actually manipulate knee extensor moments on a step-by-step basis to prescribed values here shown on the left. And these changes are accompanied by changes in knee flexion excursion. In other words, subjects are encouraged with biofeedback to overcome that quadriceps avoidance strategy underlying stiff knee gait thought to contribute to altered cartilage loading. But again, we're trying to dive deeper. We're trying to move beyond just observing things. So let's not stop there, because I think we can do better in terms of establishing cause and effect relations between altered gait biomechanics and cartilage tissue loading. So what we do here, and when we, in my lab, when we can't actually measure something directly, we leverage some of the recent developments in musculoskeletal modeling. And in our case, we're going to use a simulation pipeline called COMAC. This is, I'm just going to read it here because it's very long. Concurrent optimization of muscle activations and kinematics. And this pipeline, what it does is it simultaneously estimates muscle forces and joint mechanics, cartilage tissue contacts. And what's cool here is that we can actually simulate combinations of muscle activation, weights, and soft tissue properties to account for individual variation between people and functional anatomical variability in mechanics of tissues. Super powerful tool. So we're doing a number of things here. As just an example, let's drive that model using measured whole body motion capture and ground reaction forces from our treadmill as subjects walk using that real-time knee extensor moment biofeedback. And just to show you here, these are some of the preliminary data that we have so far. Students got group average data as of this week now that'll be ready for abstracts this season. All the data points presented here are changes relative to normal walking without biofeedback. And on the left, we can see change in anterior tibial translation. And on the right, we can see change in peak force transmitted through the ACL. And what I want you to get across from both of these is that these outcomes within the joint are sensitive to prescribed changes in peak knee extensor moment. And I want you to take away the same thing from this. We can actually estimate changes in cartilage contact force, which I've separated here into peak force on the medial tibiofemoral plateau as the closed symbols, and on the lateral tibiofemoral plateau as the open symbols. And again, just showing that modifying gait with biofeedback has emergent changes all the way down to the magnitude of forces experienced by the articular cartilage within the knee. Really powerful paradigm. And those data suggest that we can use this type of approach to augment and perhaps optimize mechanical loading in the knee to preserve or restore cartilage tissue integrity in hopes of preventing the development or maybe slowing the progression of OA. The obvious challenge there is translational feasibility. And I'll simply say, there are really terrific advances in the use of wearable sensors and machine learning that may eventually be able to overcome those challenges and allow for some scalability and feasibility in the hands of clinicians. So where do we go from here? Allow me to close here just with a new direction or application of all of this work as we merge our years of work looking at the biomechanics of movement in older adults with our more recent contributions to understanding the neuromechanical pathway to osteoarthritis and the involvement between the interaction between muscle action and biomechanics and the inflammatory state within the joint. So with new funding, we were very gracious, very happy to receive from the UNC Thurston Arthritis Research Center. We're in the process of testing the hypothesis you see here in older adults with idiopathic osteoarthritis. And that is, in older adults with OA, do the quadricep muscles succumb to the demands of lower extremity loading with aberrant lengthening action with every single step? Because if they do, this has the potential to increase inflammation and cartilage contact forces. So we're just getting ready to start subject recruitment here. We should know more about this time next year. Maybe we'll share another lunch. So with that, I really want to emphasize all the wonderful contributions of our group and our collaborators. I've put a big black box around the PhD student who's most heavily involved in this work, Mandy Munch, a fourth year PhD student in our group. And again, I really appreciate you sharing your lunch with me and giving me the chance to share a little bit about our work. And I'd be really pleased to take any questions you might have. I think I stayed on time.
You did. Thank you, Jason. I think this space in between the original joint insult and the development of post-traumatic OA is fascinating, and we still have so much to learn. So great presentation, giving us a little bit more insight. As a reminder, just like Jason said, we do have time for questions. You can type your questions in the chat box. And also in a few minutes, you'll see a poll pop up on your screen with some survey questions. So we'd be appreciative if you'd answer those before you leave the webinar. I'll start off. I have one question. How would you implement biofeedback modalities to augment joint loading and biochemistry in the real world?
Yeah, so the funny thing is right now, right, all this work takes, you know, $150,000 treadmill, $200,000 motion. It's totally ridiculous to think that there would be accessibility and equity in the delivery of some of these technologies to physical therapy clinics. But we have ongoing work that is trying to see if we can whittle all of this laboratory equipment down to a small set of wearable sensors, whether those are IMUs that you might place on the limbs, maybe plantar pressure data. Can we replicate this laboratory system in a really simple take home, take to the clinic type approach? And I think within the next, you know, I don't know, I've been really inspired by some of the developments in machine learning and all the great investigators using wearable sensor work. I think it's totally feasible. And so that's sort of my vision for where all that would go.
Thank you. Yeah, I think it's definitely important to make this relatable in a real world setting.
Absolutely.
It's great to do the laboratory work that's so necessary, but then how do we translate that? We do have a question in here and a comment. Philippe Landry says, thank you, very, very interesting. How strongly did the flexion excursion angle correlated with the KEM and the other parameters difficult to assess?
Yeah, it's a good question. So Philippe's essentially saying, you know, to get knee extensor moment, not only do you need motion capture, you also need forces. And I think what Philippe might be suggesting is, you know, is there a way to get to a surrogate like knee flexion angle, knee excursion, knee flexion angle that we could assess in the lab? These things do change in the same direction. So for example, if we prescribe an increase in knee extensor moment, you saw that's also accompanied by an increase in knee flexion excursion. So that's good news. The magnitude of change can be really different. And then what's the big challenge is I think that the way those two things relate to one another can differ by individual and different populations. So even if you had knee flexion excursion, which you might be able to just get with a camera or your phone even, if you optimize that for one person, it's hard to know how it might translate to the next person, or if you come up with some sort of, if you've made some clinical decisions on treatment based on the relationship that you found, can you then go ahead and apply that clinical decision to other people that exhibit the same amount of knee flexion excursion? I don't know. I'd certainly want to test it, but I totally understand where you're coming from, and it speaks to this idea of trying to get the science out of the lab, which is something we think about quite a bit.
Great. And we have another question from Marty. Great presentation and very interesting. Thank you for sharing your work. I'm looking forward to seeing this work in print. Did you measure muscle length from an image taken during walking or at rest?
In the study that we've published in young adult controls, uninjured controls, and then in the study that's in review in the individuals following ACL reconstruction, those we only captured images during walking. But we've since come back and we're doing a follow-up study in a lot of people with ACL reconstruction, participating in these biofeedback and doing a lot of modeling. And there we're getting static images of the quads at various knee angles. So Marty, we're trying to completely characterize the operating landscape of the quads from isolated contractions and rest. And then when we get our walking data, the vision is then we can sort of layer on, where were you? Where was your muscle during walking? And how does that relate back to some of those static measurements? Because so some clinics might have access to ultrasound, but maybe they don't have the capacity to measure these things while the people are moving. So again, it might be nice to find ways to make it easy on clinicians if things correlate.
Great. And Sherry says, thank you for sharing your expertise with us. Are there any other known mechanisms other than increased loading that will help to prevent post-traumatic knee arthritis? My understanding is that controlling inflammation is helpful.
I am going to plead the fifth. Sherry, I am new to this space, and I think it would be overstepping my area of expertise to talk about specific treatment. My understanding is the same as yours, that biomechanics are important and inflammation is important. And lessening the inflammation, whether through therapeutics or other means, is helpful in preventing osteoarthritis. I think what we add here is that those two things might be sort of fundamentally connected, that the loading, the muscle's actual behavior in response to or to generate that loading, and the resultant inflammation might be this really highly interconnected thing. So to answer there, the idea of controlling inflammation, you could do it directly through therapeutics, but if the source of some of that inflammation is the behavior of the muscle itself, then you might have to go to the biomechanics first and indirectly control inflammation. So I think it gets complicated. So I basically said I'm not going to give you an answer, and then maybe I did give you one, but Sherry, thank you for your question.
Okay, and another question from Philippe. Thanks for your initial data seemed to show that more AP translation came with higher loading, but was that increase good or was it considered exaggerated?
Yeah, so the data that I've been able to present so far has been on single subjects, and we haven't really put too much emphasis on it. And that's why, Philippe, you identified a specific result, and what I did when I presented was like, look, these things change, right? Because I don't want to put too much emphasis on the specific directionality or the specific magnitudes. I am waiting for the morning, which could even be like tomorrow. Mandy, who I mentioned, is at the very end of these simulations are incredibly difficult. They've taken about 18 months to work through. And I think it's any day now where we'll actually know, does higher loading change knee, anterior posterior translation in this direction? Does it increase or decrease ACL force? Does it change tibiofemoral plateau cartilage contact forces in this direction by how much? So stay tuned.
Wonderful. Well, thank you so much. And we are at the end of our 30 minutes. If anyone is typing a question as I talk, feel free to keep typing and we'll answer it. The poll just popped up on your screen, and I just want to thank everyone for joining us today. Please join us in next month for our January 19th Lunch and Learn, featuring our good friend Ellen Schneider, who will present on expanding the arthritis appropriate evidence-based intervention menu. So we look forward to sharing that with you. And in the meantime, thanks again, Jason, and to everyone, we hope you have a wonderful holiday season, and we'll see you next month.